It's my great pleasure this morning to open the James Rankin Oration for today. It's one of APSAD's most important annual responsibilities to select the orator. And we have Jim Rankin sitting in the audience. Welcome, Jim. The James Rankin Oration is an oration held since 1990 as part of the conference, and it honours Jim's significant contribution to a research practice and policy. It honours a significant contributor to research practice and or policy in Australasian alcohol and drugs. The oration is named in honour of APSAD's first president, Professor James Rankin, who established the first medically based combined clinical and academic program for the treatment and study of alcoholism in Australia at St Vincent's Hospital in Melbourne in 1964. In 1978, Jim became the Director of the Drug and Alcohol Division within the Health Commission of New South Wales. In 1994, Jim became Chair of the Central Sydney Area Drug and Alcohol Service and Clinical Professor at the University of Sydney. In 1999, he moved on to work as Senior Staff Specialist in the Northern Rivers Area Health Service. And if you'd like to learn more about Jim's illustrious career, please read the section in the University of Sydney's 150 Years, 150 Firsts, The People of the Faculty of Medicine. James Rankin orators at the APSAD conference are a list of weight and immense contribution to the sector, and just looking through the list is quite impressive. People like Dr. Ingrid Van Beek, Associate Professor Ted Wilkes, Ian Webster, Robin Room, and the list goes on. And this morning it's my great pleasure to introduce Professor Amanda Baker. Just getting there. Amanda is a senior researcher at the University of New South Wales. She's a senior clinical psychologist who has worked in mental health, alcohol and other drug and forensic settings in the UK and in Australia. Located at the University of Newcastle School of Medicine and Public Health, her research has been supported by NH and MRC fellowships continuously since 2003. She's co-director of the NH and MRC Centre of Research Excellence in Mental Health and Substance Use. And Amanda leads an internationally renowned program of clinical research, trialling novel interventions that target coexisting mental health and substance use problems. The title of today's talk that Amanda will be speaking to is Motivational Interviewing and CBT to Reduce Substance Use Problems and Improve Mental Health and Wellbeing. I'd like you to join me in welcoming Amanda to the podium.
Thanks so much. It's such an honour to be here, very unexpected and a delight. So I'm greatly appreciative of this opportunity. So I'd like to start by giving some acknowledgements. I've really got very fond memories of my clinical training. You know, once you've done it and you're over it by about 30 years, you sort of start to look back fondly on these things. And a few names here. Peter Wilson at Sydney Uni was a great clinical supervisor. And then I did my PhD at NDARC. Very fond memories of those tumultuous times with Nick Heather, Alex Wodak and Richard Mattick supervising my PhD. And I don't know if Wayne Hall's here today, but he gave me a lot of stats advice and I'm still no good at stats. I had the fantastic opportunity to work in clinical settings with team leaders who allowed me to do lots of research as well. And all through my clinical career, I've been able to combine research and clinical work. So for any clinical team leaders, if you can, allow your researchers to do their research as well, that's a fantastic opportunity. And for my academic career, thanks so much to Kylie Bailey, who's led the course in drug and alcohol at University of Newcastle. Well, I've continued on this research-only path, and my good colleague Richard Velleman from the University of Bath, who I've worked closely with over the years. I've supervised many talented students, many of whom come to this conference and others and are now leading their own research careers. It's been a real privilege, and I wish, I had your real talent, which, many of you have just been stars. And my continuing collaboration in Australia and overseas, it's been wonderful working with such a great bunch of people. So thanks so much for coming along today, Professor Rankin. I'd like to acknowledge your role in my career. New South Wales Health did actually give a grant to University of Newcastle to start the Drug and Alcohol Studies course, and I remember you coming up to visit us, and that was a great privilege to have had that grant from New South Wales Health and kickstart the course, which we're continuing to run so well with Kylie's guidance. I'd like to cite Jim, quote his words here, that the drug and alcohol area doesn't fit into any single professional area, it's truly interdisciplinary. And as Mark Farrell was saying yesterday, APSAD provides a forum to bring such world-leading researchers, clinicians and others together. We truly have a fantastic group of alcohol and drug workers who come together annually, and it's a real privilege to be giving this oration at APSAD. So what I'm going to talk about today is what I know best, is basically a clinical presentation, and talk about, I've just come from the early career breakfast, a little bit about my experience as a clinical psychologist, and particularly might be helpful to clinicians who are hoping to do some research in the area, and then illustrate some of the findings around motivational interviewing, CBT, particularly with methamphetamine, alcohol and depression, and tobacco, and then move on to talking about a more holistic healthy lifestyles approach with recommendations for practice. And if we've got time for questions, that'll be good. So what I was saying at the early career breakfast this morning is that I'm getting old. I graduated in 1984 from Sydney Uni as a clinician with my clinical psychology degree, and got a job in a community mental health centre, ostensibly to treat people with high frequency disorders, depression and anxiety problems. But what happened within a short time of arriving in that setting was that deinstitutionalisation was underway, and suddenly in the public system we were expected to see people with schizophrenia and bipolar disorder, and people with the high frequency problems like depression and anxiety were expected to source their own treatment privately. So it's, I guess my career message is to roll with the punches and take the opportunities as they come, and that was, a fantastic opportunity to get new experience. And in the course of that position, I was able to do a job exchange in the UK and actually have 3 years experience in training in CBT in schizophrenia, and that was wonderful to see how well they combine research and clinical practice. And I've taken that with me throughout my career. As I said in the breakfast this morning, I took a job at NDARC. Of course, it was in walking distance from my mum's house back in Sydney. And I happened to stumble across the lucky finding that Bill Miller and Steve Rolnick were actually working for a whole year at NDARC, and we got fantastic training in motivational interviewing and supervision. It was really, a fantastic experience. And I was able to do my PhD with Nick, Heather and Alex Wodak in the time of the HIV epidemic. And I don't know if many of you are old enough to remember Rock Hudson, but he's one of the sex symbols of the time who sadly passed away from AIDS during those years. And I did my PhD on HIV risk reduction among people who inject drugs, so that was a wonderful experience. So moving on from that mental health, drug and alcohol sort of background, people, including myself, started to get interested in what we used to call dual diagnosis, that overlap between mental health and substance use disorders, and that became the main focus of my research at that time. And we all know that the dual diagnosis, the duality as has been said, is in the service and not in the system. People will experience multiple mental health and drug and alcohol problems, but our treatment silos are built separately, and we're having to deal with that. So I've worked in mental health settings, referring people out to drug and alcohol services. I've worked in drug and alcohol services, trying to refer people with mental health problems. If you've ever tried to refer in that direction, it's very, very difficult to get much graft there. And it's a really hard system, I think, that we've created for ourselves. I did work in a very forward-thinking service where I used to counsel people, and then the drug and alcohol worker was integrated into our team, but they would go in and counsel the person separate to me, and then I would re-enter the room and they would leave, and that was how our drug and alcohol counselling went sort of back 25 years ago or so. Now, Marie Thiessen, who's the Director of the Centre of Research Excellence in Mental Health and Substance Use, is going to talk next. And so she's done some fabulous work, obviously, in comorbidity, and she's written that whilst Australia has focused some research effort on comorbid mental health and substance use problems, comorbidity with physical disorders also warrants attention, with the evidence for the most appropriate treatment response to these comorbidities being particularly limited. So I'm adding another silo to our challenge, and I'm particularly interested in this area. And I think drug and alcohol is really the meat in the sandwich between mental health and physical health. And what brings people into treatment is often not the drug and alcohol use, but the substantial mental health problems and the physical health problems that people are experiencing. And I've started to focus more on that three-way overlap than the two-way overlap. Of course, in doing so, it's all a little bit artificial because we keep building sort of different silos. We know that tobacco services are quite separate to alcohol services and other drug and alcohol services, and we're often building additional silos for, understandably, but we're just separating services all the time in the drug and alcohol setting. And also we're doing that in the mental health setting as well. So we tend to have separate services for separate conditions, certainly still for people with psychotic disorders from other mental health conditions. And I think that kind of sets us up for sometimes not having as much clinical experience in some areas as we'd like, and we're losing confidence as clinicians in our ability to address some of these overlaps. In addition to that, Victoria Manning and colleagues at Turning Point have recently done the pathways analysis study, and in addition to physical and psychological outcomes not being quite as well as we'd hoped after treatment, we're finding out that social and environmental problems remain below Australian norms. So when people finish treatment, the overall standard of living, quality of life isn't very high. So what are we going to do? I'm close to retirement age, so I'm probably going to be doing this soon. Ditching the silos in some sort of way probably isn't the answer. Do we have one integrated service where we address everything for everyone? It's impossible, we can't do that. So I guess I'm going a bit back to basics today and talking about what I think we can do, and talk about doing what we do as being actually very helpful. And I think that's the main thrust of my talk today, is that we're capable of doing excellent, high-quality work, and I think we have to keep that in mind. So Jim Orford has published this work on excessive appetites. This is the second edition of his book there. And from a psychological, again, talking from a clinical psychological point of view, this sort of work has informed my approach, where addiction is seen as an excessive appetite, and the core elements of addiction are really skewed consumption. People are using something too much, and they're having trouble exercising restraint. And what maintains addiction is the positive incentives that these learning mechanisms come into play. And there's lots of reward in that rapid emotional change that people experience. And then wide cue conditioning happens, and people develop cognitive schema about the positive aspects of drugs, the need for drugs, and how helpful they are, until they start to experience the adverse mental health and physical health symptoms associated with use, and start to experience conflict between continued use at that level and the sorts of adverse effects that they're experiencing. So in this model, addiction is seen as a strong attachment to an appetitive activity. What drives people to keep using drugs and the sense of returning to drug use after long periods of abstinence is that strong attachment. People like using drugs, they do lots of good things for them, they enjoy it, and that is often what brings people to relapse after long periods of abstinence or reduced use. During the time of heavy use, self-control is diminished, and behaviour can appear to be disease-like, but it's that diminishment in self-control that is essential to this problem of strong attachment and excessive appetite. So what is treatment about, or what is behaviour change about? In terms of this model, it's about giving up excess. It's not necessarily about giving up, it's about giving up excess. And giving up or reducing use is a natural consequence of that conflict that people start to experience between their current level of use and where they want to be. So much change actually happens outside of expert treatment, and we have to acknowledge that that's really important. We need to help people make their own changes and very much be supportive of consumer and other organisations, because many people, if not most, actually do a lot of this without any expert help. And then what does that mean for us as clinicians? Well, I think coming back to basics, and certainly what we see in the methamphetamine area, we need to build up our own confidence again as a field. And in fact, coming from a background of, in the old days, psychoanalysis and very long sorts of treatments, the behaviour change process, the treatments that we can offer people are actually a lot more basic and applicable to people more universally than previously thought. So that's where I'm going to talk about motivational interviewing and CBT today. We're all probably very skilled in those areas, and I think we need to remember how skilled we are and how effective they are. Motivational interviewing is a client-centred approach to help people strengthen their motivation to change, to work with that conflict or that ambivalence that is normal to excessive appetite, and to build a plan for change. Then cognitive behaviour therapy is basically working together, the therapist and the client, to change thoughts and or behaviour to improve these other mechanisms there. So it's working together with the client. And that's what I want to emphasise too today, that it's not only what you do, it's how you do it that is really, really important, and it's probably more important even than what you do. So Bill Miller and colleagues have published widely on this, and without empathy, warmth and good reflection and consistency in your motivational interviewing, you won't get as good results as you would if you were making a good relationship, working alliance with the person. And this involves seeking client feedback and acting on that feedback. One of the things I'd like to suggest today is, as a field, I'm not sure how well we measure that within our services. How often do we look at the quality of the therapeutic relationship in the service, how the service presents overall when you walk in the door, and how each clinician working in that service provides an empathic, empowering therapeutic relationship and works with clients. So I'd love to work more on that and more more of that later in the talk, but I think we could do a lot more measurement and training in that direction. So I'm going to talk about methamphetamine and then alcohol and tobacco, just by way of illustrating the power of what we can already do. The work that we've done in Australia in a pilot trial and then an RCT quite a few years ago now, both trials showed that when you compare a control condition or 2 or 4 sessions of MI and CBT, that people who did at least 2 sessions of the MI-CBT had double the rate of abstinence 6 months following baseline. And that of those people who did more sessions, they were had showed improvements in their mental health as well. A third wave of CBT is amongst us, and I think it's a really positive third wave. I think we need to keep incorporating these new things into our field, and there's been a study looking at acceptance and commitment therapy and methamphetamine uses by people in South Australia, and they did an RCT comparing 12 sessions of ACT with the 4 of CBT in the type that I've just described. What happened in this trial was, as we'd expected in our earlier work, people only attended 3 sessions, so we have to be realistic. And in terms of outcomes in this trial, ACT and CBT were equally efficacious in terms of reducing methamphetamine use and depression. However, hair samples, physical outcomes and polydrug use favoured the CBT, and there was high attrition in the study. I'd really be interested in collaborating with anybody who's interested in more ACT and CBT and other approaches. I think we really need to pursue this line. People, we're just talking with clinicians here earlier, people really seem to like the ACT approach. Among people who already have an existing psychotic disorder, we've done a number of trials, and in this particular trial we did an RCT comparing 10 sessions of motivational interviewing and cognitive behaviour therapy versus just assessment only. And although people had a variety of substances used to come into the study, 42% of this sample was had methamphetamine abuse or dependence. And there was a large effect for motivational interviewing and CBT at 12 months for these people who already had a psychotic disorder. So MI-CBT is effective for methamphetamine use. We know that. There's been a lot of hype around we haven't got a treatment for methamphetamine. We sure do have a treatment for methamphetamine. What is it as a field that we're not getting that message across? We could probably investigate contingency management more, which has had success in the States, but how well that transfers to our culture is worthy of further study. We certainly need to work on involving families more, and the cognitive aspects of methamphetamine are a challenge, so we can break down treatments into more accessible bites. And the healthy lifestyle issues associated with methamphetamine are such that the physical and mental health problems really draw people into treatment, so we can probably help to engage people more in treatment through addressing those. And we need to work on the maintenance of change, which I'll get back to in a minute. So that's methamphetamine. I'm moving on now quickly to alcohol and depression. We've done some work in that area with 3-year follow-ups in what's called the DAISY trial. But just before I tell you the results of that trial, just to let you know, just to remind you that we have found recently in Victoria Manning's work that in the Pathways trial that reliable reductions are lowest in of all the substance types following treatment in alcohol. So alcohol is in need of a bit of a makeover for our treatment. We need to look at what we're providing and whether we can zhuzh it up a bit and do come up with some better outcomes. In the DAISY project, we randomly assign people just to a 1-session brief intervention or to a single intervention which either focused just on depression or on alcohol, or there was an integrated intervention where they could focus on depression and alcohol. And the upshot of that trial was that people who receive even brief interventions do show significant reductions in depression and alcohol, but overall a longer intervention of around 10 sessions does give better results, with little difference between the alcohol intervention or the integrated intervention, so that the integrated intervention would lead to a quicker reduction in depression in the short term, but by 6 months, 12 months, the alcohol and the integrated intervention were the same. The single focus not to administer is depression. If you just treat somebody's depression and don't address their alcohol, then their alcohol use doesn't change. So that's really important, particularly in mental health settings. So in short, just a quick overview of what we need to do in that area. We do know that MICBT is effective in this space. We do know that involving families and social networks is helpful for a lot of people. Working clinically, there are a lot of people who are cognitively challenged, so you're probably working more on a behavioural basis rather than a cognitive one. And the diet and other healthy lifestyles areas are really important in this space as well. And we need to look at maintenance. And that in the Pathways project was found to be enhanced by attendance at mutual aid. So I think as a country we need to look at what provisions do we have following treatment and probably start to evaluate how helpful approaches are, such as smart recovery and 12-step approaches following treatment, because we've got high rates of relapse following the end of the treatment episode. So tobacco, in all of this work, certainly in the 80s, I'm puffing away with everybody, smoking away in my office with my clients, having a lovely old time. And, didn't even think of addressing tobacco. Why would I? Well, a lot of us have thought the same, and we're kind souls, and we've often thought that, how could you take the smoking away? Their lives are so bad already. So kindness is kind of killing people with mental health and drug and alcohol problems. We've been scared about reducing their smoking because they might increase their drug and alcohol use or get worse mental health problems. And anyway, we haven't had to worry about it because it's not like methamphetamine, because you don't get that acute behavioural disturbance. And what if people just lost it completely and got all aggressive if we told them they couldn't smoke and they can just go and buy NRT anyway? So it's been an easy substance to ignore, but just generally we've been getting bad press around the life expectancy of people with mental health and substance use problems being a national disgrace, and that people with these problems die 20 to 30 years earlier than the rest of the community, with cardiovascular disease being the single cause of death. And so the most common causes of death, as you can see, are heart disease and cancer and respiratory diseases. And what is common to these and core to our drug and alcohol field is smoking and drinking. And in addition, these cluster of behaviours that go together, diet and inactivity. And as a behavioural scientist, I'm interested in working with my medical colleagues and APSAD to reduce the physical health problems that people are experiencing in our field. If you are healthy on those 4 behaviours, if you don't smoke, you eat well, you do lots of exercise and you don't drink too much, there's a 14-year longevity benefit. So certainly by changing your behaviour, we know on an epidemiological basis it is beneficial. So smoking in drug and alcohol treatment populations is very high. At least 3/4 of people attending those services smoke. And we know from Pete Kelly's work and others that those attending, say, residential treatment have tried to quit, and about 2/3 are seriously thinking about quitting. We do get quite good cessation and reduction rates, certainly no worse than what you get in the general community in drug and alcohol trials. From a clinical point of view, what I want to point out here is that if Judith Prochaska's done this work, we had her at an APSAD Congress a few years ago, and she just had smokers. These people are in mental health hospital, they're all smokers, and these are all the sort of health risk behaviours they might be engaging in, including drug and alcohol use. And when you look at whether they're prepared, people are prepared in the next month to change their behaviours. So they're all smokers, and the least popular one is tobacco. So even though a quarter do want to change their smoking in the next month, that's the one. That and cannabis people are finding hard to shift. So what we have to do as a field is think about how to motivate people, and everybody, just about everyone, is interested in better mood regulation and stress management. Interestingly, stimulant use always comes up high, and that had the best treatment response in Manning's Pathways project. People in treatment for methamphetamine do really well. They're motivated to change. People who are in treatment really want to change. So we need to pair smoking with how it's interfering with stress management and emotional regulation. So I'm interested in how we use MI and CBT to do cleverer combinations. We don't have to just chip away at these individual silos. Bonnie Spring and colleagues in America, in Chicago, have been looking at this. It's feasible, it's effective, it's more efficient to combine health behaviours, including smoking and drug and alcohol. So we embarked on a series of studies. We've looked at smoking among people with psychotic disorder, and then we started to combine it with, say, weight. In this pilot trial, we found that people could reduce their smoking and also significantly reduce their weight at the same time, which is exciting because people use smoking to control their weight. And we've then started doing randomised controlled trials in the healthy lifestyles area, where we're compared face-to-face versus telephone interventions. We've moved on to look at the feasibility of just telephone interventions to get these MI-CBT approaches disseminated. I'm really interested in not meeting people face-to-face. Can we do it just on the phone? And we got very, very good results just by telephone delivery. So the RCTs that we've got in progress in this area are in peer delivery, particularly working with Pete Kelly in mental health settings, Near My and Mind, and group settings within residential rehab. And also I'm particularly interested in getting Quitline on board to reduce smoking, together with Billy Benevsky and others, in people with drug and alcohol problems, so working in that area. So just to summarise on the RCTs, before I move on to my conclusions, just mental health and substance use and physical health risk factors clustered together. We can assist people to work on a few behaviours at a time if they want to, and it can be very motivating because it allows flexibility. If they don't want to work on their alcohol use, maybe they do a little reduction, but they're interested in working on their activity or diet or whatever. It allows people to experience success over time. So from the physical health point of view, a lot of people with physical health problems, the ones that kill people, have serious mental health and drug and alcohol problems. So I've been working in head and neck cancer with cancer researchers and others to look at mental health, smoking, alcohol and diet interventions. Still the most common cause of head and neck cancer is smoking and alcohol use. We've been working in cardiac rehabilitation, and Billy Benevsky's just got a stroke grant to look at multiple risk behaviour change to prevent second stroke. So lots of people who've experienced that smoke and drink. So drug and alcohol users aren't young forever. They start going on to experience these problems, and we need to be in that space helping people to reduce their drug and alcohol. Working with Leanne Hydes by telephone again, completely by telephone, no face-to-face contact, MICBT to help young people who are disengaging from work and school. And we're also evaluating how people go in smart recovery but are still intending an RCT there. So firstly, to conclude, got a couple of conclusions so I don't get too excited. MICBT is effective. We can target multiple behaviours. We have to work, I think, on including family, getting people to use mutual aid groups, giving them a try, and using the telephone as well. I'm really keen to embark on a bit more of a trajectory in terms of helping services to improve the quality of the existing psychosocial interventions that we've got. So I'd be interested in talking with anyone after this if they're interested in looking at therapeutic processes as well as content to look at maximising treatment outcomes. And just to point out that I have given you a very narrow focus today. James McCain Addiction recently said we need to go beyond interventions focused on the individual or family and to include local, community and national policy. That's exactly what APSAD does. It brings us together to provide cleverer, overall comprehensive interventions and approaches to drug and alcohol problems. So I'd really encourage you to keep working together and I think be proud of what we've achieved within Australia in drug and alcohol treatment and continue to improve it. My tip for the day is who shot the barman? That's it. Thank you for listening.